Takayasu Arteritis 1. Introduction. Takayasu Arteritis is a rare, chronic, progressive, granulomatous, large vessel vasculitis that primarily affects the aorta and its major branches, including the carotid, subclavian, and renal arteries. It is also known as pulseless disease because the inflammation leads to thickening and narrowing of the arteries, resulting in weak or absent peripheral pulses. The disease typically affects young women of childbearing age, especially in Asian countries, and can lead to ischemic symptoms involving multiple organs, including the brain, heart, and kidneys. If untreated, it can cause severe morbidity due to vascular stenosis, aneurysm formation, or organ failure. Definition. Takayasu arteritis is defined as, open quote, a chronic, idiopathic, inflammatory, and granulomatous disease of the aorta and its primary branches, leading to stenosis, occlusion, or aneurysm formation of affected vessels. Close quote. It is classified under large vessel vasculitis, LVV, according to the American College of Rheumatology, ACR. Etymology. The condition is named after Dr. Mikito Takayasu, a Japanese ophthalmologist who, in 1908, described a peculiar retinal arteriovenous anastomosis in a young woman with absent radial pulses. Subsequently, similar vascular lesions were identified in other patients with diminished pulses, leading to the naming of the disease as Takayasu arteritis. In Japan, it is sometimes referred to as aortic arch syndrome or pulseless disease. Namhata 4. Epidemiology. Prevalence. Estimated at 2 to 3 per million population, though higher rates are reported in Asia and South America. Gender distribution. Strong female predominance, female-male ratio 8 to 9:1. Age group. Most commonly affects individuals aged 10 to 40 years, particularly women in their second and third decades. Geographic distribution. Common in Japan, India, Korea, China, and Southeast Asia, but cases are found worldwide. Ethnic susceptibility. More frequent in Asians and Hispanics than in Europeans or Africans. Number 5. Types based on angiographic classification. According to the International Takayasu Conference, Numano classification, 5 types are recognized based on arterial involvement. Type, arteries involved. I, branches of the aortic arch. 2A, ascending aorta, aortic arch, and its branches. Tube type 2A plus thoracic descending aorta. 3. Thoracic descending aorta, abdominal aorta, and/or renal arteries. Abdominal aorta and/or renal arteries. V. Entire aorta and its branches, most extensive form. 6. Causes. The exact cause of Takayasu arteritis remains unknown, but evidence points toward an autoimmune etiology triggered by genetic and environmental factors. Proposed causes include autoimmune mechanisms, abnormal activation of T cells and macrophages attacking vascular endothelium, genetic predisposition, strong association with HLA-B52 and HLA-B39 genotypes, infectious triggers, possible link with Mycobacterium tuberculosis, streptococcus, and viral infections, hormonal influences, female predominance suggests hormonal involvement, inflammatory cytokines, overproduction of TNFi, IL-6, and interferon GANG contributes to vessel damage. Number 7. Risk factors, female gender, especially 40 years old, Asian or South American ethnicity, family history of autoimmune diseases, genetic markers HLA-B52 positive, chronic infections, especially tuberculosis, immune dysregulation, and inflammatory disorders. Number 8. Complications. Chronic inflammation and fibrosis lead to narrowing, occlusion, or aneurysm formation in major vessels, causing complications such as hypertension from renal artery stenosis, cerebrovascular accidents, stroke TIA, due to carotid artery involvement, aortic aneurysm or dissection, heart failure or myocardial infarction, claudication of limbs, pain due to ischemia, retinopathy and visual disturbances, pulmonary artery hypertension if pulmonary arteries are involved. Number 9. Pathophysiology. Takayasu arteritis is characterized by autoimmune-mediated inflammation of large arteries. 1. Initiation. In genetically predisposed individuals, antigen-presenting cells activate CD4 plus T lymphocytes, leading to cytokine release. 2. Inflammation. Cytokines IL-6, TNFi, IFN-GANG recruit macrophages and giant cells, forming granulomatous lesions in the vessel wall. 3. Destruction. Elastic tissue and muscle cells of the media are destroyed, weakening the vessel wall. 4. Healing. Fibrosis leads to intimal thickening, luminal narrowing, and thrombosis. 5. Outcome. Results in stenosis, occlusion, or aneurysm formation, leading to tissue ischemia and organ dysfunction. Number 10. Stages of disease. 1. Systemic pre-pulseless phase. Nonspecific inflammatory symptoms, fever, malaise, arthralgia, fatigue, and night sweats. 2. Vascular, occlusive phase. Vascular inflammation causes thickening and narrowing of arteries, leading to diminished pulses, bruits, and hypertension. 3. Fibrotic, chronic phase. Chronic scarring results in fibrosis, irreversible vessel stenosis, or aneurysm formation. 11. Signs and symptoms. General symptoms: fever, fatigue, weight loss, malaise, arthralgia or myalgia, night sweats. Vascular symptoms: absent or weak pulses, especially in upper limbs, blood pressure discrepancy between arms, 10 milligrams, bruits over carotid, subclavian, or abdominal arteries, claudication of arms or legs, syncope or dizziness. Organ-specific symptoms: neurological, headache, visual disturbance, stroke, vertigo, cardiac, chest pain, dyspnea, heart failure, renal, hypertension due to renal artery stenosis, ophthalmic, retinopathy, vision loss. Number 12, medical diagnosis. 1. Laboratory findings: elevated erythrocyte sedimentation rate, ESR, and C-reactive protein, mild anemia of chronic disease, elevated cytokines, IL-6, TNF-A, autoantibodies usually absent, helps differentiate from lupus vasculitis. 2. Imaging studies, CT or MR angiography, identifies arterial thickening, stenosis, occlusion, or aneurysm. Conventional angiography, gold standard for diagnosis and classification. Doppler ultrasound detects blood flow abnormalities in affected vessels. PET scan detects early inflammation before structural damage occurs. 3. Diagnostic criteria, ACR 1990. Diagnosis is made when 3 or more of the following criteria are present. 1. Age at disease onset, 40 years. 2. Claudication of extremities. 3. Decreased brachial pulse. 4. Blood pressure difference 10 millimeters between arms. 5. Bruit over subclavian arteries or aorta. 6. Arteriographic abnormalities. Number 13. Nursing diagnosis. 1. Ineffective tissue perfusion related to vascular inflammation and obstruction. 2. Activity intolerance related to fatigue and muscle weakness. 3. Risk for altered cerebral perfusion related to carotid artery stenosis. 4. Acute pain related to arterial inflammation. 5. Knowledge deficit regarding disease condition, medications, and self-care. Number 14. Medical management. Corticosteroids. Prednisolone is the first-line therapy, 1 milligrams killing day to control inflammation. Immunosuppressive agents. Methotrexate, azathioprine, cyclophosphamide used as steroid-sparing agents. Biologic agents: tocilizumab, anti-IL-6, infliximab, anti-TNF, or etanercept for refractory disease. Antihypertensive drugs: ACE inhibitors, ARBs, or calcium channel blockers for blood pressure control. Antiplatelet therapy: aspirin or clopidogrel to prevent thrombosis. Surgical endovascular interventions: angioplasty or stenting to relieve stenosis. Bypass graft surgery in severe cases. Number 15. Nursing management assessment. Monitor vital signs, especially blood pressure in both arms. Check peripheral pulses and limb temperature. Observe for signs of ischemia or neurological deficit. Interventions: maintain rest during acute phase. Administer prescribed corticosteroids, immunosuppressants, and monitor side effects. Encourage adequate nutrition and fluid intake. Educate on medication adherence and lifestyle changes. Provide psychological support for chronic illness management. Monitor for complications such as stroke, hypertension, or heart failure. Number 16. Treatment options. 1. Pharmacological: corticosteroids, prednisolone, immunosuppressants, methotrexate, azathioprine, biologic therapy, tocilizumab, infliximab. 2. Interventional: angioplasty or stent placement, vascular bypass surgery. 3. Supportive: antiplatelet agents, blood pressure and lipid control, regular follow-up imaging for disease monitoring. Number 17. Psychosocial interventions 5. 1. Counseling: helps patients cope with chronic illness, uncertainty, and body image concerns. 2. Patient education: explaining disease process, medication use, and lifestyle modifications. 3. Support groups: connecting with others facing similar challenges reduces isolation. 4. Stress management: techniques like yoga, meditation, and breathing exercises. 5. Family involvement: encouraging family participation to improve adherence and emotional stability. 18. Prevention: primary prevention, not possible due to unknown etiology. Secondary prevention: early recognition and prompt treatment of symptoms. regular monitoring for relapse or vascular changes, lifestyle modifications, smoking cessation, balanced diet, exercise, control of blood pressure and cholesterol to prevent complications. 19. Conclusion. Takayasu arteritis is a chronic, life-threatening autoimmune vasculitis that primarily affects young women. Early diagnosis is crucial to prevent irreversible vascular damage. With the advancement of immunosuppressive and biologic therapies, prognosis has significantly improved. Comprehensive management involving medical treatment, nursing care, psychosocial support, and lifestyle modification helps enhance quality of life and reduce morbidity associated with this rare condition. Thank you. Have a nice day.